We're going to continue our discussion of men's health. Our next topic is going to be prostate, cancer of the prostate, or prostate cancer. You'll see the abbreviation CA capital P used for prostate cancer. Your reading assignments are required IGGY chapter 75, and then I pulled some things from the Nursing Reference Center for you to look up. Prostatectomy, radical, cancer of the prostate, and then prostate cancer, cryosurgical ablation therapy. All of those are interesting and will give you some good information and reinforce what you're seeing in your textbook. So we're going to look at the incidence, the etiology and the pathophysiology, clinical manifestations, the assessment, treatment, and nursing care of prostate cancer in the male patient. When we look at the incidence of prostate cancer, we see that there's a 16 to 20% lifetime risk of being diagnosed with prostate cancer, 75% greater at age 65. So as we get older, the risk for prostate cancer goes up. But you look at the mortality of cancer, only 3% have a chance of dying from prostate cancer. It is the second most leading common diagnosed cancer in men over the age of 50 in the United States. That's after skin cancer, and it's the second leading cause of death from cancer in American males, even though it's a small percentage. So you can see that there is some problems with it. One of the things that I found interesting as I was doing my reading is that socioeconomic status is known to play a role in prostate cancer mortality, with lower socioeconomic status associated with a greater risk for death. And think that looking at some of that, they think that it's because the people don't come in at later stages of the prostate cancer. They don't get the follow-up, they don't get what they need, and so they're finding them at much later stages of cancer, and so it's much more difficult to treat than that. When we look at the etiology, pathophysiology of prostate cancer, not 100% sure. We do know that the prostate cancer are androgen androgen specific, that they do respond and do grow in the presence of testosterone and DHT. They are a dependent adenocarcinoma. Your book talks about something called PIN, which is prostatic. I got to find it again. I'm sorry. The PIN stands for prostatic intraepithelial neoplasia, and that is from a rapid growth of the prostate gland in reference to the testosterone and DHT, which are your major androgens for the male hormones. It's different from benign prostatic hyperplasia. These particular type cells are more likely to turn into cancer cells, so you have to watch these closely. Do know that basically prostate cancer is one of the slowest growing cancers. It's very slow going, and as you see in the treatment, sometimes the treatment is just wait and watch, because it may take 10 years before we see any type of problems from this. The bigger thing is if we wait too long, prostate cancer does metastasize, and it tends to spread in a common pattern. The sites that you typically see when metastasis of prostate cancer, of course, are the nearby lymph nodes, bones, lung, and liver. When we talk about bones, we're really talking about the bones of the pelvis, the sacrum, and the lumbar spine are most likely affected when we look at the spread, the metastasis of prostate cancer. So what are the risk factors as we look at prostate cancer? We'll break those down into modifiable and non-modifiable risk factors. When we look at non-modifiable, of course, as you get over age 65, there does tend to be an increase in the rate of prostatic cancer. Family history, we're talking first-degree relative who has had prostate cancer before the age of 65. That tends to be a thing that we look at, and as you're doing your history, you'll ask about, have you had a first-degree relative? And if there's numerous first-degree relatives, that puts them at a higher risk factor of developing prostate cancer. Being black, African American, it does seem that it is a higher instance in African American males than Euro American males. And then certain genetic factors tend to play into this process, and you will see later when we draw the labs that there's special tracking type labs that we'll draw as we look at that. Modifiable factors, of course, we're always talking about something the person can do to actually make it better for themselves to reduce their risk of developing any type of cancer. And we look at prostate cancer, that is true as well. Stopping smoking. Smoking has been attributed to, many cancers. When we look at lung cancer, we look at heart disease, we're looking at many issues, but it does tend to affect the prostate as well. Occupational exposure, what we're looking at, people who work with substances such as pesticides and other agricultural products, cadmium, paints, rubber products, polyaromatic hydrocarbons, those are from coal and liquid fuel combustion products, metallic dust, and certain types of lubricating oil and grease. All of those put the person at greater risk. Elevated testosterone levels, we've talked about that testosterone tends to cause an increase in the growth of the cells, and it does increase the cancer cells growth as well. Diet can play a big role as we look at these patients. The high consumption of red meats and processed meats, and meats cooked at high temperatures have been associated with increased risk factors, and also the advancement and the metastasis of the prostate cancer. Obesity tends to play a role. We see it more in obese males than we do males who are within the normal BMI. We can help this. We can, when we talked about diet, go back and look. A diet high in omega-3 fatty acids thought to be helpful in preventing cancer. Also reinforced to your patient the need to increase fruits, vegetables, soy, and high fiber foods as part of their diet. All of those can tend to help prevent prostate cancer. Unfortunately, we're here in the South where we see these high fat, high red meats, animal fats. All of those tend to cause more problems. One of the things that I found interesting, though, is when we look at it, dairy products and calcium tend to increase the risk for that. So we need to be, you have to, though, be careful. We need the calcium, so we may need to look at other ways of getting calcium for these patients. So what are some of the clinical manifestations of prostate cancer? Symptoms don't typically occur until the cancer is late in progression. So the majority of your patients are going to come in hopefully for their routine physical and their routine PSA and routine digital rectal exam. That's when the majority of these prostate cancers are found, because it is typically patients are asymptomatic until we're really seeing a big change and maybe even metastasis of this cancer before we actually begin to see symptoms. Symptoms may include hematuria, which is blood in the urine, pain down in the pelvic area, down into the rectal region, kind of a heaviness in those areas. We may see changes in elimination pattern. Just like with BPH, the growth may be so that we're seeing a narrowing of the urethra coming out, so that we're seeing a changes in that. Also remember that prostate is there next to the rectum, and as the growth continues, it can push out into the rectal area and actually begin to cause problems with the elimination of the bowel as well. So all of those are some things that you may see with our patients who have prostate cancer. So what do we do? What are we going to do in our assessment of this patient to find out what's going on and see if they have prostate cancer? Now, some of these you're going to do as a nurse as part of your intake, especially if they're coming into your hospital or into your clinic. Some of these are going to be the advanced practice nurse or the physician that will be doing those. But these are some of the things in the assessment history-wise. We're going to assess for risk factors as we do in any other disease process. Does this patient have any risk factors for prostate cancer? If they tell you they have a a first-degree relative that had prostate cancer before age 65, kind of moves them up the top of the list as you look at those. And then you start looking, do they have the other risk factors that fall under this that will continue to increase their risk factors for that. Ask them about urinary flow, hesitancy, nocturia, hematuria, all of those type things that may indicate there's some sort of blockage. Now, those also can be part of that BPH that we talked about earlier, but you need to know about those. Ask them about a history of sexually transmitted infections or sexually transmitted diseases. These diseases can lead to more cancers, especially if we're looking at HPV, even though HPV is more of a skin type thing, but you still need to ask, and as we look at those. Ask about scrotal pain or swelling. As the disease progresses, it can metastasize into those areas. Also ask about pain, especially in the pelvic region, the spine, the hips, or the ribs. Again, because the metastasis goes to those areas, especially in the bones, these patients may complain of bone pain as we're looking at those. Now, physically, what we're going to do is we're going to do a physical assessment. Focused assessment is going to look at doing a digital rectal exam and then checking the lymph nodes. One thing, and I didn't mention it when we were talking benign prostatic hypertrophy, and one of the things we're going to draw on these patients, and same thing we will do on BPH, is a PSA. Draw your labs before you do that digital rectal exam, because stimulation of that prostate can cause changes in the PSA, the serum acid and alkaline phosphatase. All of those can change as part of that process. So make sure you draw your serum labs prior to doing the digital rectal exam. Very important to do those. But again, the digital rectal exam is going to be done by an advanced practice nurse or the healthcare provider. Your role is to basically prepare that patient, have everything ready for your provider so that it goes very quickly, and reassure your patient about what's going to happen. Definitely want to look at lymph nodes in the inguinal region, looking all around those areas to see if there's any involvement in lymph nodes in those areas. Diagnostic-wise, of course, we're going to get a CBC, we're going to get a urinalysis and a urine culture. We're going to draw that PSA. We're going to draw an EPCA2, which really is more of a specific type lab, looking at the early prostate cancer antigen is what the name, and it actually can show up before elevations before the PSA shows up. So it's just kind of getting both of those. You know, if you knew the PSA was already elevated, you wouldn't have to draw this. But because you don't know in these patients, this may be something you draw as well. When we look at the serum acid phosphatase and the serum alkaline phosphatase, patients with advanced prostate cancer often have elevations of the serum acid phosphatase. And if they have metastasis to the bones, you're going to see elevated serum alkaline phosphatase levels. So those need to be drawn to look at those. The transrectal ultrasound, again, is to look for the size and the shape and to look for any nodules within the prostate. Again, your role is to prepare that patient for about what's going to be happening. Ultimate diagnosis is actually to do a needle biopsy, stick a needle into that prostate, into where you think that tumor is located, and then get a grade of the cancer from that point. A CT and MRI are done to see, again, look for metastasis. If we suspect metastasis, we need to get those. If we suspect there is metastasis to the bone, we'll need to do a radionuclide bone scan to see how significant the metastasis is on this patient. Again, your role, again, is just educating the patient and reassuring them as these tests and getting those taken care of with these patients. Now, the other thing is the BRCA2. There are some genetic mutations in the prostate cancer, and this is a more aggressive type, and that can be seen with the BRCA2 mutations. This is the same thing that you were hearing just recently in the news with Angelina Jolie having both breasts removed. She had a positive test for this. So it's associated with breast and ovarian cancer, but also associated with prostate cancer. The other thing, the most common genetic factor that increases the risk of prostate cancer is a mutation of the glutathione S-transferase gene. And it's normally part of the pathway that helps prevent cancers. I'm not going to ask you a question about that, but thought it might be something you would be interested in. Now, when we start talking treatment of these patients, remember we talked about that this is a very slow-growing type cancer. So in many cases, the physician may choose what they call watchful waiting. This watchful waiting would need to be discussed with the patient, the urologist, and also maybe with an oncologist to see what the best treatment is for this patient. Remember, again, it's very slow growing, and if I have a patient that has very significant disease processes going on other than this, significant cardiovascular disease, end-stage renal disease, is this something that we want to put this patient through at this time? If I have a patient that's 80 years old and it has not metastasized and we're just now finding a lump in the prostate, do I want to put this 80-year-old through all the surgeries, all the chemotherapy, all of those type things when we don't know the life expectancy? So it's kind of a discussion that has to be done with the patient. You continue to monitor these patients on an annual basis with digital rectal exams, with PSAs, to see if there's any increases. Now, if that patient begins to develop any type of symptoms, such as changes in urinary flow, pain, those type things, then we bring them back in and begin the treatment process. But again, it's kind of one of those that you need to basically be discussed. That patient needs to we need to make sure that patient totally understands what this watchful waiting is. It's not that we're going to not treat this patient, but it's such slow growth that we do not need to treat right at this point in time, and we need to just carefully monitor them and see what's going on. Now, other treatments basically are minimal invasive surgery type treatments, the laparoscopic radical prostatectomy, cryotherapy, and the transrectal high intensity focused ultrasounds. All of those are some different types of processes that we may look at. Now let's talk a little bit about the laparoscopic radical prostatectomy, or you may see it called the LRP procedure. In this procedure, the urologist makes one or more small punctures or incisions in the abdomen and then introduces the laparoscope with a camera on the end of it, of course, and it basically goes in and basically then goes to the area of the prostate. And the using either can be used by the physician or can be used with robotic devices, but the prostate is removed and any nearby lymph nodes can be removed using this. The advantages of this basically are that it decreases hospital stay, there's minimal bleeding with this, the incisions are smaller so there's less scarring, less postoperative discomfort, decreased time for urinary catheter placement. Of course, that's one of the big things we're looking at today to prevent infections, fewer complications, faster recovery and return to usual activities for these patients. And the big advantage is nerve sparing, in that typically these patients will not have problems with erectile dysfunction when we use these type processes. But again, there are disadvantages to it in that you may not be able to get to all the lymph nodes with this. So you really can't do a good check of all the lymph nodes. There's not a good visual check of all the lymph nodes like there is with the radical prostatectomy. Okay? So that's just one of the things. Now the cryotherapy. The cryotherapy basically it's a surgical technique for the prostate cancer. And what it does, it destroys the cancer cells by freezing the tissue. A probe is inserted through the tissue, basically into the prostate gland. Usually goes through the rectum, so it's a transrectal ultrasound probe is inserted to visualize the prostate. Then that probe is inserted into the prostate. This probe contains liquid nitrogen, which is very, very cold. It is then injected into the prostate, and it basically freezes the prostate tissue and the cancers. It destroys that tissue. Treatment takes about 2 hours and is typically done under general or spinal anesthesia. Does not involve an abdominal incision. There are some complications that go along with it because you can get fistulas that develop between the rectum and the urethra. That's rare, but it can happen. You can get tissue sloughing. There is a chance for erectile dysfunction because, again, this is going to freeze the entire area, so you may get nerve damage as part of that. You can get urinary incontinence from it, and hemorrhage has been one of the big problems that you can see with the same process. Now, the transrectal high-intensity focused ultrasound, basically you're going through the same way as that, and you're just using high-intensity ultrasound to actually burn. It's almost like a microwave type process where you're actually burning that tissue, very similar to what we talked about with the cryotherapy, only you're using a different means for that patient. When we look at actual gold standard of treatment for prostate cancer, we're really looking at that radical prostatectomy, where we're actually going in and openly looking at the prostate, and we can actually openly look at the lymph nodes in that area to see if there's been metastasis to the lymph nodes. There are two approaches that can be taken. The most common is the retropubic because it gives you a better opportunity to look at the lymph nodes. Now, again, you have surgical scars that are there, so there's always that issue sometimes with patients. And then there's the perineal aspect where you go in and you actually make an incision basically between the perineal region and the rectum. And you can see there's some problems with this because you're going to have an open wound near the rectum, so you have to be very careful not to spread bacteria from the rectum to that wound. So frequent dressing changes, changing the dressing every time this patient has a bowel movement. The big thing is there's less of a scar that can be seen with these patients. You cannot, with this perineal type process, see all the lymph nodes as easily. So it's not as common as the retropubic because of the lack of ability to visualize the lymph nodes. When we take care of a patient that's had this radical prostatectomy, we need to make sure that we understand what kind of care they're going to require. They are going to require pretty intensive care after the surgery, especially if we're looking at that retropubic, because many times they're in there, they're looking, they're trying to fiddling around with everything, and the surgeries can last a long time for these patients. So we really want to treat them almost like they've had abdominal surgery. So these patients may come back with an NG tube in place. You can always get paralytic ileus from these, so you need to observe them carefully. They're always going to have a catheter in place. Typically, those catheters are going to have a 30 milliliter balloon in place there. A drain typically is left in the surgical site to drain those, so you'll need to make sure you're monitoring the output from that drain. It's typically removed after a couple of days. Again, major complications that follow either one of these are erectile dysfunction because of nerve damage and urinary incontinence. The instance of erectile dysfunction basically depended on the patient's age, preoperative sexual functioning, and whether nerve-sparing surgery was performed. A lot of it has to do with expertise of the surgeon. If it does return, sexual functioning tends to take time. It may gradually return over 24 months or more. In these patients, sometimes medications such as Viagra can help with the sexual functioning. Other problems that we talked about is urinary control, and these patients may have urinary problems for a few months following the surgery. And a lot of that has to do because the bladder had to be retracted to get to the urethra. One thing we'll do is teach these patients about Kegel exercises. Now, we're typically teaching Kegel exercises to our ladies, especially our postpartum ladies, to kind of help strengthen that. But men can also benefit from these as well. Other complications are typical surgery type complications, hemorrhage at the site, wound dehiscence, and the big thing with these patients is we've got to get them up, get them moving, because there's always a risk of deep vein thrombosis and pulmonary emboli, and you may see that in the text as VTE process. That's a combination of the deep vein thrombosis and the pulmonary embolism. I'm going to come back to the slide. This is nursing diagnosis that can maybe be related to prostate cancer. We'll come back to that, but we want to look more right now at the post-op care after this radical prostatectomy. Encourage the patient to use the patient-controlled analgesic device as needed. They are going to be in a lot of pain. This is an open surgery. There's been an incision in the skin, so they are going to have pain. You need to monitor and do all your other things you can for pain, making sure they understand to treat the pain early. Do other things to help with the pain, visualization, any other thing you can do to kind of help with the pain. Help that patient get out of bed in a chair on the night of surgery and ambulate by the next day. Again, that's to prevent those deep vein thrombosis and those pulmonary embolisms from developing. That's one of the things that we as nurses can do to make sure that doesn't happen. While they're in bed, we want to maintain those sequential compression devices until that patient is ambulating on a routine basis. Monitor your patient for deep vein thrombosis and pulmonary embolisms. You know the signs and symptoms, so make sure you're doing that. Keep an accurate record of intake and output, including that Jackson Pratt or whatever drainage device is in that wound. And then, because this patient has a catheter in place, good catheter care, keeping that urinary meatus clean with soap and water. Remember, that can be designated to your assistive personnel, but you need to make sure that is being taken care of. Again, avoid any rectal procedures or treatments on these patients, especially if you've gone through the perineal aspect to get to the patient. These patients may go home with a catheter, so you need to be teaching these patients how to care for that urinary catheter, what they need to do at home, teaching them how to use a leg bag at home so they can be up and around. Emphasize the importance of not straining during bowel movements. Typically, these patients are going to be put on stool softeners to help prevent that. You want to remind them to drink plenty of fluids to help keep that bowel movement soft. That, along with stool softeners, will work with that very well. And then remind your patient about the importance to follow up. Very important they follow up their surgeon and their physicians to make sure they're progressing well, there's no signs of infection, that they are doing well with this process. Now, when we start talking about other types of treatment, of course, we've talked about treatment by surgery. You may see these type treatments done instead of surgery, and you may see this external beam radiation done in addition to surgery to just make sure that everything is, if they weren't able to get the entire prostate or had issues. But two treatments that can be done instead of surgery are external beam radiation and what they call brachytherapy. Let's talk about external beam first. Basically, it's the most widely used method of delivering radiation therapy for those with prostate cancer. Once the cancer is confirmed, and we know that cancer is confined to the prostate and the surrounding tissues, the patients are then treated on an outpatient basis 5 days a week for 4 to 8 weeks. Each of these treatments will last only a few minutes, and of course there's always side effects from this radiation. And they can occur if they are called acute if they occur during the treatment of the first 90 days. Acute, again, basically, or when you say acute side effects from the radiation, those occur during the treatment or within 90 days following the cessation of treatment. When we talk about chronic type problems, those occur after 90 days, within years after that. Some of the more common acute side effects that you're going to see involve normal tissue, including the skin. You may see dryness, redness, irritation, pain at those areas. The GI tract, you may be seeing diarrhea, abdominal cramping, you may see some bleeding. Urinary tract, dysuria, frequency, hesitancy, urgency, nocturia, all of those. Additionally, some side effects may affect sexual functioning, erectile dysfunction. Chronic type things, you may see fatigue, bone marrow suppression. So some of those may be going on for a while. Most of the problems, though, usually resolve 2 to 3 weeks after the completion of radiation therapy, especially if the patients with localized prostate cancer, it's very localized. The cure rates are very good with this. They're comparable with that radical prostatectomy that we see. So, it is a choice. If it is localized, this is a good treatment option for that patient. Now, the brachytherapy basically involves placing radioactive seed implants into the prostate gland. It allows higher radiation directly into the tissue, and it spares the tissue around there. So we're really sparing that rectum and bladder. They're placed within that gland with a needle through a grid template guided by transrectal ultrasound. This basically ensures placement. Now, we need to make sure it's a one-time thing, one-time procedure. And many patients find this more acceptable because they don't have to come in every day, and they don't have time to come in every day. And it is best suited for patients with stage A or stage B prostate cancers. The most common side effect is the development of urinary irritative and obstructive type systems because of that. Now, a lot of teaching needs to go on with these patients to let them understand that this radiation is not going to spread outside their body. It's not going to affect their families, that their families can be safely around them during this time. So they need to make sure they understand that process as well. Biggest problem with this is fatigue, and that may last for several months after the treatment stops. You can go back to chapter 24 in your book. It really talks more about the general nursing care for patients having radiation therapy to look at those type issues. Other treatments, basically, and you may see these treatments along with the radiation therapy and along with the surgery just to prevent any kind of problems. Remember, we talked about that the cancer can be related to overproduction of testosterone and DHT. And as we look at these medications are going to help stop some of that production of those hormones in these patients. Major ones that you're looking at here are your LH and RH agonists. These are your Luprons, your Zoladex, Trelstar, Suprafact. These are all part of those type processes. They basically work and block the body's availability to use androgens. They're for the major treatment for metastatic diseases in these patients. They work very well in slowing down that whole process as we're looking at these patients for these cancers. The LH-RH antagonists, again, let me back up and just say something again because I think I said it wrong. When we look at the LH-RH agonists, they actually, if you'll look on page 1640 of your textbook, it talks about hormone therapy. And again, because most of the prostate tumors are hormone dependent, patients with extensive tumors or metastatic disease are usually managed on these type hormones. Now, the LH-RH agonists, basically, they stimulate the pituitary gland to release the luteinizing hormone. And after about 3 weeks, the pituitary gland runs out of the luteinizing hormone, and which reduces testosterone production by the testes. So it actually burns out the luteinizing hormone, so testosterone can't be produced. The antagonists also work. The LH-RH antagonists work by blocking the LH receptors, and because these receptors are blocked, there's an immediate testosterone suppression. Some of the side effects from these drugs can be redness and swelling at the injection site because these are injectable, and we can see elevated liver enzymes with these medications. Now, the other ones we see are the androgen receptor blockers. Androgen receptor blockers, they basically block the action of testosterone by competing with the receptor sites. These drugs have side effects of loss of libido, erectile dysfunction, hot flashes, breast pain, and gynecomastia may occur with these drugs. Now, many times you'll see the LH, RH agonists or antagonists used in conjunction with the androgen receptor blockers. So you may see those as well. Another drug that can be given is estrogen, or DES, diethyl stilbestrol. It inhibits the LH secretion, decreases testosterone production, and blocks circulating testosterone. Big side effects from this are breast enlargement, and then cardiovascular complications such as myocardial infarction, deep vein thrombosis, and cerebral vascular diseases. So those are some of the things. Now, the other thing that can be done is actually surgical removal of the testes. When you do that, you remove 95% of the testosterone source so that there is no chance of testosterone being produced. This is pretty severe and usually only done when there's severe metastasis with these patients. Of course, there's problems that can go along with this thing. These men will have weight gain, have a loss of muscle mass, and it can alter the physical appearance of the male. Again, other side effects can be hot flashes with this, erectile dysfunction, loss of sex drive, and irritability, and then also osteoporosis. So if a patient goes this route, we need to make sure that they are on some type of medication to help prevent osteoporosis for these patients. Now, chemotherapy can be done as well. When we see there's two different types of cells that we look at. If we have small cell cancer, then the cisplatin and etoposide is used. But if we're looking at the hormone refractory prostate cancer, especially in late stages, a different type is used, and many times combinations of medication is used. That will be decided in conjunction with the patient, the urologist, and the oncologist to make a decision. Other drugs that can be used is ketoconazole. Your book talks a little bit about that. I'm not going to get deeply into that process as we go along. Now let's back up quickly and just take a quick look at some of the nursing diagnoses that you may see that goes along with prostate cancer. And these are pretty typical when we talk about these patients. Decisional conflict related to numerous alternative treatment options. That patient needs to be part of that process of deciding what type of treatment. If it's metastasized, do we go with chemotherapy? Do we go with radiation therapy? If it's localized and it's a very small, do we watch and wait? Do we go ahead and go in and try to do a needle biopsy? Do we try to freeze that area? All of those things need to be taken into effect as the patient does that. Acute pain related to surgery, always, and especially bone metastasis. Bone metastasis is very painful for these patients. Urinary retention, a big problem. Impaired urinary elimination, of course, is something. Constipation. Sexual dysfunction is one of the big things, and that's one of the things that most men will ask about when you start talking about surgery of the prostate. Am I going to have problems with erectile dysfunction? If I do, what can be done about it? How can I maintain my sexuality as I go through this process? And there's always going to be anxiety related to uncertainty of the outcome of the disease process, uncertainty of the surgery as well. So all of those are big things that you're going to look at as we move forward. Just kind of in summary, understand that prostate cancer is a very slow-growing cancer. It tends to affect men greater than age 65 mostly. It is something that we need to deal with and we need to take care of. One of the big things we as nurses need to make sure that we're doing, and this is one of the things that we have to make sure that we're out promoting, is healthy behavior, health promotion. We need to be teaching men about the most recent American Cancer Society guidelines for prostate cancer screening. These came out in 2011, and the current recommendations are that men should basically have prostate cancer screening starting at the age of 50. Now, if they have a first-degree relative that has had prostate cancer, may need to start as early as 40. But it's as simple as going to see your family doctor, having a PSA drawn, and getting a digital rectal exam. It's not that bad. It's real easy to do, but we need to make sure. Most men will put that off. They do not want to go in and see a physician. I will tell you, most men, if they happen to have a female physician or a female nurse practitioner, are not real thrilled with that person doing a digital rectal exam on them. It is very embarrassing. As nurses, we need to make sure that we help them understand this is necessary. This is a medical procedure. It's no different from any other type of medical procedure. And as always, we need to encourage a healthy diet, healthy exercise, a steady body, a good body weight within the normal BMI. All of those are things that we need to make sure we help patients understand. But it is our responsibility to promote health and health promotion. That's one of the things you're going to see much more in the future is health promotion. All right, that's all I have on prostate cancer. Hope you have a good day.